Good evening, everyone, and welcome to the CPT Category 2 Coding CME webinar. And before we start, I'd like to go over a few housekeeping items with you all. Please ensure that you have completed the registration for today's webinar and provided us your email addresses. This is especially important if you are a physician attending this webinar, as there is a CME of 1.0 available, and for us to deliver those CME credits to you, those certificates to you, we will need that email address. We will have a question and answer session towards the end of the presentation. At that time, please dial *1 to enter the queue for questions, and then the operator will unmute your line at that time. We have a webinar evaluation survey towards the end as well. Please make sure to provide your feedback to us. It is important. And again, for physicians attending the webinar, you will need to complete the survey to obtain your CME credit. Here's what we plan to cover during our webinar today. In a moment, we'll introduce the speakers you'll be hearing from. You'll be hearing an overview of a clinically integrated organization and what it means to be a participating provider in a CAO. And we'll also review the CI measure program and the data capture for those quality measures. And second segment, we'll be reviewing an overview of CPT Category 2 codes and also reviewing some steps of how to go about implementing, capturing those codes in your practice. We'll also have some time for Q&A towards the end and administer the CME evaluation survey. Hearing from me, I am Dr. Sahana Sharan, and I'm Tenet's National Director for ACO Clinical Operations. I lead the implementation and provide ongoing support for our clinical integration programs across the market. And I also am responsible for building and implementing clinical care management strategies for Tenet's ACO arrangements with the payers to demonstrate improved costs and quality. I'm a physician by training, and I hold a Master's of Public Administration degree from New York University. In the second segment of today's webinar, you'll be hearing from Rebecca Vandiver. She is the National Director for Tenet's Physician Practice Coding. She has over 30 years of progressive healthcare experience, and she specializes in physician and staff coding and documentation utilizing CPT, HCQS, ICD-9, and ICD-10 code sets. She's a certified coder and coding instructor with the American Academy of Professional Coders and is an approved ICD-10 trainer with the American Health Information Management Association. So let's start with an overview of what clinically integrated organizations are and what it means to participate in a CIO. Clinically integrated organizations are physician entities where physicians agree to come together to collaborate and coordinate care for their patients. That includes physicians that are both employed and private practice physicians in the community. And the goal really is to develop clinical initiatives to control costs and improve quality, and as a result of these collaborative efforts, to improve the overall quality, provide high-value, low-cost care to the patients. Ultimately, we are able to collectively negotiate for the quality-enhanced reimbursement from commercial health plans by doing that. And there are governance structures and technological infrastructures to support us in the execution of the larger population health management goals. And many of Tenet's markets today have clinically integrated organizations in place, and they range in their evolution from relatively more advanced to just starting to take shape. And in order to participate in a clinically integrated organization, physicians sign a participation agreement. It also means that physicians should be in a good standing at a Tenet facility and maintain active credentialing status with health plan, and actively participate in a CI clinical program and adopt the clinical integration measures and submit data on some specialty-specific measures, which include the use of Category 2 codes. So how are these measures selected? What exactly is a clinical integration measure program, and how do we obtain data for those measures? So the physician board members of clinically integrated organizations oversee the development and maintenance of these CM measures, and the measures are referenced and sourced from nationally recognized entities such as CMS and NCQA. CMS references Physician Quality Reporting System measures. Those are frequently abbreviated as PQRS measures. And NCQA references HEDIS, which is Healthcare Effectiveness Data Improvement Sets. So those are commonly referred to as HEDIS measures. And these measures are focused on recommended evidence-based guidelines and interventions that are important to the purchasers. And as we improve on our quality and also putting together those population health management initiatives, these measures will play an important role. Specialty has certain specialty-specific measures that are applicable and relevant to that specialty. Currently, we are in the process of getting 2015 measures approved for the various CIO markets, and once the board approves them, the CIO directors will be communicating them to the practices. Here's a sample of internal medicine measures. What it includes is the source of the measures, the list of measures, and description for each of those measures. So what you see on here on the left-hand side, it references where that measure was sourced from. Is it a PQRS measure, HEDIS measure? And then the actual measure itself, and then the description of what exactly accounts for that measure. To obtain data for the measures, there are two primary ways in which we are able to capture and report on the data for these measures. For measures that are claims-based or hospital-based reporting, we are able to automatically capture data on the back end from the hospital systems, and commonly include measures such as patient safety, measures such as any hospital-acquired infections, readmission rates, and even the Joint Commission measures that are required for reporting. And the second type of data capture that we need the practices to capture those CPT Category 2 codes are the measures that require CPT Category 2 codes. Require that the practices submit these via claims, and these are ambulatory measures that are PQRS-based. And the two sources of data together will generate physician performance dashboards. In turn, will help us establish baseline data for quality improvement purposes. And when you receive your specialty measures for 2015, they will include a section or a quick reference guide to CPT Category 2 codes, and we will review a sample of what that looks like in just a little bit. So are CPT Category 2 codes? And to provide an overview for that, these are non-billable codes and are clinical quality codes that facilitate the reporting of data in an ambulatory setting. They typically describe clinical components, lab or radiology test results, and processes that reflect patient safety practices. CPT Category 2 codes were developed by Performance Measures Advisory Group, and that is comprised of entities you have heard about, such as CMS and Joint Commission, among others. So why are CPT Category 2 codes important to your practice? As we enter into value-based contracts with purchasers, more and more payers require that they require some data collection and submission on measures that they're not able to obtain based on the claims. And also allows organizations to establish a baseline for performance and in turn identify opportunities for improvement for physicians. And it also removes the burden of retrospective chart reviews in the practices. The CMS PQRS program requires data collection and submission to avoid financial penalty. I do want to call out here that although PQRS is referenced as a metric source, reporting data to meet the CIO measure criteria may not simultaneously satisfy reporting requirements for your PQRS incentive payment from CMS. I'd like to turn it over to Rebecca Vandiver to go over the details of implementing the CPT Category 2 codes in your practice. Rebecca, I can advance the slides for you whenever you're ready.
Sorry, I was on mute. Now can you hear me?
Yeah, I can definitely hear you.
Awesome. I'm so sorry, I had it on mute. Required to report our Category 2 codes for a given visit if the criteria for the denominator has been met. The denominator actually describes eligible cases for a measure or eligible patient populations. An example of that in just a minute. The denominators are identified by ICD-9, CPT, and HCPCS codes, as well as patient demographics such as age and gender. We're going to report these codes as often as the metric requires it, and the reporting frequency will vary with a measure, but the typical reporting period is 12 months unless otherwise stated. You might ask the question, do we have to report these Category 2 codes on all of our patients? And the answer would be yes. We report them on every patient as long as the denominator has been met, regardless of the patient's insurance. Next. This is the example that I was alluding to just a minute ago. If you'll notice, step 1 is our denominator. The criteria for this denominator is the patient's age of being 18 to 75. We have our eligible ICD-9 codes. If you'll notice, the first one is your diabetes code, 24.00, and your eligible CPT codes. Notice the office visit codes, 99201 through 99215, are actually listed there as a denominator criteria. So if we have a patient that comes into our office today who's age 18 to 75, we're going to report an office visit, for example, 99213, and the patient's diagnosis is diabetes, 250.00. We'll notice that the denominator criteria has been met, so we'll be triggered to report a Category 2 code for this patient, regardless of the insurance that the patient may have. Then we'll move to step 2, which describes the numerator. The numerator describes actions that are required by the measure. These codes represent the outcome of that action. They're called quality data codes, QDCs, and they're represented by those Category 2 codes or the temporary G codes, the HCPCS codes. And as Shahana mentioned earlier, these are not payable codes. So to give you an example, if that patient that came in was in the ages of 18 and 75, and we were going to report the 99213, the diabetes code of 250.0, then we're going to look to see what our numerator code should be. So we're going to be prompted to review our patient's lab results and determine the results of the most recent hemoglobin A1C and report the code that actually fits that criteria. For example, notice you would report code 3046F if the patient's most recent hemoglobin A1C was greater than 9. Or we would report code 3044F if the patient's most recent hemoglobin A1C was less than 7%, and so forth. So we would pick the code that most appropriately represents that patient's hemoglobin A1C. Next slide. Talk about how we're going to work the capture of these codes into your workflow. We're going to talk about paper charting, but remember that if you're using an EHR system, your vendor will have specific instructions for you on how to capture these codes and how you need to code them in your EMR system. So if we're talking about paper, you make something that you call a super bill or an encounter form or a charge ticket. What paper mechanism is for you to capture your codes, you're probably going to want to update that with the most relevant CPT Category 2 codes for your practice for the specialty measures that you have elected. So you'd want to add those on that encounter form. When you're finished with your patient, you're going to circle your numerator code as your denominator code. And remember, you have to report on your claim form both your denominator and a numerator. If you forget to report the numerator code, the Category 2 code, you cannot go back later on and submit a claim with just your numerator on it. So both numerator and denominator have to go out on the claim form. So with those circled on our encounter form, and then that piece of paper is going to go to your biller or your coder, who's going to input those Category 2 codes onto your claim. Next. This example that we pulled from the CMS website will show you a completed 1500 form with your Category 2 codes listed. You'll note this practice on line 1 was going to report an office visit of 99213 for diagnosis of diabetes 250.00, which triggered them to use their Category 2 codes for the specific measures that they had selected to report on. The Category 2 codes are always reported out with a charge of 1 penny in cost F. As we mentioned before, these are not payable codes, so you will not get paid for that penny, but you can have that penny on there for that claim to take it out the door over to the payer. Those pennies will get denied, and then you will write them off, depending on how you take your how and when you take your write-off. Please note that more than one Category 2 code can be reported on a claim. This place actually has 5 Category 2 codes on the claim form because it was specific to the measures that they had elected to report on. So you can have more than one. So just to summarize what we talked about with completing your 1500 form, you want to ensure that you report your denominator codes, which are your CPT and your ICD-9 codes that are applicable to this measure, and report the appropriate Category 2 code on your claim form with a penny charge. And remember, there can be more than one of them, more than one of the Category 2 codes on your claim, and then pennies will be denied and you will adjust them off. Next slide. Example of a quick reference guide that will show you the source of a measure, the measure and the measure description, as well as your numerators and your denominators. So these quick reference guides are available through your market representative, so you'll need to contact them to get your specialty-specific quick reference guides. These guides, I'd recommend that once you get them, you print them and you put them next to your coder, maybe back in the doctor area where they're marking up the encounter form. So everyone has this as an easy reference guide to help you with this process, making sure you're getting all the appropriate Category 2 codes reported out on your claim. The process and the resources that are available to you. I'll turn the presentation back over to Shahana for closing remarks.
Again, this is a quick reference guide, and to kind of orient you to what will be included in that metric packet that you will be receiving from your CIO market directors. Each specialty will have a list of measures that were chosen by the CIO board, along with the description of that measure and what the abstraction setting for that measure is. Is it inpatient or ambulatory? And so the denominator section, like Rebecca was talking about earlier, is a definition for what qualifies or what are some of the eligible cases that you need to pay attention to in order to trigger the capture for the numerator codes. And numerator codes are the actual CPT Category 2 codes that you will then place on your encounter form as a physician that you then hand it over to your court that puts it on the claim. So it's something that we will communicate to your practice through your respective market directors. And since we're in the process of finalizing these measures, we will then communicate it to you in the coming weeks. Again, the intent here is to assist the practices so they can start accurately capturing those codes that are then reported in terms of the physician dashboard. And list of your market representatives that you are familiar with for each of your respective regions. And again, they will be in contact with your practice to communicate the specialty metric packets that will include the quick reference guides.